What I'm going to share with you is the story of what I've been up to for the last few years and then get into the particulars of it. So 3 years ago, I found myself, I was in Arizona. I was the president and CEO of the Arizona Hospital and Healthcare Association. I went down there in 2013 under they had some very trying circumstances. They needed an organizational turnaround, and they wanted to pass Medicaid expansion in the conservative Arizona legislature. And so I signed a 4-year contract in 2013 to go down there and do that. I never thought I'd last more than 2 years. There were actually bets whether I would last more than 3 months because it was such a bad environment for what it was I had to do. Actually, things went extraordinarily well. And almost 7 years later, I found myself saying, that's enough of this. I got to go do something else. So it was in 2019, 3 years ago, where I said, okay, I'm stepping down as the CEO. And I'd worked all my life since I was about this tall, delivering newspapers. And I said, well, at least I'm going to get a little break here. I wasn't really intending to retire. And so I'm just going to go off and spend the rest of the year and do some stuff. And then, I'll get around to it the next year. So I did what I did and through that year. And then got to 2020, and I went on a music cruise in late January, early February. And we were going out of Miami, out in the ocean, listening to music and getting drunk on a boat. And didn't really have much internet connection or any desire to really have it. But every once in a while, I would get to a port, and I'd get my phone out, and I'd start checking things. And one of the things I did in Arizona to help that association, I thought was a really important thing, was we brought some coordinated disaster planning for hospitals. In fact, the whole healthcare system for if horrible things happened, like pandemics. So I was getting all these weird messages from a lot of my colleagues and friends from those days. And I was telling my wife, there's some really weird stuff going on in China. We need to be a little cautious about what's going on here. Well, long story short, by the time we got back to port in Miami, it was time to get back to wherever we wanted to get to really quickly, or we weren't going anywhere for a really long time. So suddenly I found myself in Arizona, locked down with the rest of the world, going, well, what do I do? We lived in this nice little community, it has a golf course. Even the golf course shut down. So it was like, okay, what do I do now? Somehow going back to work in that environment seemed like a really bad idea. So I said, okay, there's got to be something here. So I cast about for what might be my next thing to do. And a couple of things occurred to me. One is, there's this thing called the Washington Health Foundation, which I'm now the volunteer president of. It's something I actually created and ran for 20 years in Washington State. It came out of some ideas for how to leverage Medicaid that I had to help the state get out of some budget crises, and poured hundreds of millions of dollars into the state and to the healthcare system. And part of it needed to go to a foundation, the Washington Health Foundation we created. And it was under a condition that we really tried to use the money to do good. So we were intentionally spending it down over the course of 20 years. Originally, we thought it would only last a couple of years, maybe 3-5 years at most. But we continued to grow. And at one point, we had an organization, the annual budget was $8.5 million a year and 50 employees. We were doing all sorts of really cool things. Well, over time, we finally started to run out. And it was about the time I actually got the call to go to Arizona, so things worked out well there. But the foundation was kind of left to sort of semi-shut down. And I agreed to be on the board, not that I could spend any time doing anything with it. And so it was just sort of sitting there. And so me and a couple of board members got on emails and said, well, why don't we try to figure out what we might do with the Washington Health Foundation and what's left of it. And what's left of it is mostly a little bit of money and a ton of boxes that are in my garage in Union, Washington. So I said, well, I can start working on that, and sort of a volunteer project. The other thing, though, that occurred to me was I had always had this thing when I was a little kid. I wanted to write the great American novel. I don't know how you get wired to do that when you're 5 years old, but I was. And so, in fact, I had started to do that in about 2010 when the foundation first started to say we're starting to see less money. So I carved out a little time. I wrote 70 pages. And the Arizona job happened like that. Literally, I had to be there the day after I was hired. And my wife was left to take care of everything, like moving the house, because I just had to go to the legislature and get to work. So it was just sort of sitting there, and sorry, I lost my train of thought here already. I am a little rusty. I read the 70 pages and pulled it out and said, that's not bad. That's actually pretty good. And the funniest thing about it, though, not really funny, but kind of weird funny, was it started with a pandemic. And because even back in 2010, I knew that there would be a pandemic sometime in the United States, and we'd have to be ready for it. So there was a body, this is how the story starts, there's a body in this cabin in Kent, and it looks like it's the beginning of the pandemic, and something has to be done about it. That's what I had written in 2010. And I said, if that's not a sign I should finish this book, I don't know what is. So that's what I started to do. Every day I'd get up and write for like 5 hours, and many months later, picked it all up and said, I have 650 pages, it's a novel, woohoo. And what I thought originally was, I would just go somewhere to Kinko's or something, put it all together, bind it, and have one copy, and I'd stick it on my desk and say, done with that, where are the golf clubs? But I also sent it to a few friends, some of whom were avid readers, and many of whom were retired healthcare executives. And since it was about healthcare, I said, well, what do you think of this? And to a person, they all said, this is really good, you should try to publish it. So long story short, 2021, last year, became a matter of me trying to get the book up to snuff so it could be published. So it was rewriting, editing, juggling things around, clarifying things, going through the entire process of proofing multiple times. And then it was also learning about what does it take to publish a book, which I had no idea about. And we kind of stumbled along that maybe I'd do it. Self-publishing is a better way to go than traditional publishing. So long story short, see if I can work technology. December of last year, I became a published author. The Theory of Irv, an American health policy detective story. So that's where you can get it on Amazon. There's a video I did on the Washington Health Foundation website. Also got some cards out on your tables. I encourage you to go online and buy it. It's only 99 cents as an e-copy. I'm keeping it discounted. There's a paperback copy. I'm working on an audio version. It'll be out probably June or July. And if you do check it out and you like it, please drop a review in. I've sold about 250 copies now, got 40 great reviews. I need more reviews in the Amazon world of selling things to really get the thing rolling where they advertise it. But I'm feeling pretty proud about it. Again, 200 people plus bought my book and like it, then I'm a happy camper. But we're going to try to get a little bit further with that, including with what we do today. So let me just tell you a little bit about it. And it is a novel about American health policy. And most people, when I just say that, they go, wow, that's got to be the driest novel ever written. And it's not. The bulk of the book actually is a medical detective story with all sorts of weird twists and turns, and characters and villains and heroes and bad things happening, good things happening. And most people have described it as a page turner. There really are exciting things going on. But cut into it is important lessons about American health policy, why the American health care system got the way it is today, and more importantly, what we can do about it. And it was written really for primarily lay audiences to get an understanding about the system so we can bring greater understanding out to the population at large so we can do something about fixing it in practical ways that might work instead of the usual political ways we try to have this fight and have had this fight for over 100 years. So that was the aim of the book. And I'm going to talk to you mostly about the policy parts of it. But I did have to read to you a section of this to give you a sense that it really isn't dry health policy. I challenge you to say if you can find this kind of language in any health policy article or book you've read. Irv, that's the central character in the book. Irv awoke to noise within the room. He was still lying bound and blinded on the stretcher where he had been left some time ago. He could hear voices speaking Spanish, more voices and louder than when he was wheeled into the room. He couldn't fully understand all that was being said, but thought he made out several pleas for help. There were responses of un momento, and he heard footsteps moving across the floor. There were odors too, food and body. It was the unmistakable smell of a hospital unit, a combination of antiseptic solution and body waste fighting for dominance in the air. 15 minutes later, he was still lying on the stretcher with his blindfold in place. All he could do was listen and wait. Then he sensed someone moving closer to him. Hands touched his shoulder and made their way to his head. They were undoing his blindfold. It took a couple of minutes to clear his vision when the blindfold was removed. The lights in the room were bright, and Irv squinted as the ceiling light shone in his face. In 20 seconds, he was able to make out the basic features of a face looking over him, a middle-aged woman wearing a nurse's uniform. She had a flat affect, neither smiling or frowning, and kept alternating between looking at him and the contents of a medical chart hooked to the stretcher. He could see that the other patients looked quite sick. Some were moaning, many were semi-conscious, and few looked like they were on the road to recovery. There were 15 men, he thought, age running from their 20s to maybe their 50s. He saw 3 women, too. All looked to be well beyond middle age. His instincts from many years of working in a hospital told him that the patients looked more like candidates for an ICU, not a residential setting where mostly custodial care would be provided. Still, this room was a better alternative than some of the possibilities he had imagined in the scenarios played in his mind over the last week. So, the challenge is you can give me a passage in another health policy article that has anything like that, then you get a free copy of my book. So what I'm going to do today is really talk about the other parts. You're going to have to read the whole book, I'm sorry. You've got to get it to get the fiction part of it. But I'm going to talk about an overview of the history of American health policy, some of the ideas for change, and then we can have some time at the end to dialogue about some of these ideas. And especially the ideas for change, because I really constructed them, again, in this notion of some just interesting common sense ideas for how we might go about trying to fix this beast, which has not worked the way it should for many, many years. So maybe some of you are students of American history and American healthcare and think you might know American health policy. We're going to start with a did you know? It's not as much work as the last session, but how many of you know about the Committee on the Cost of Medical Care from 1932? Nobody? Come on, one. It's not uncommon. People in health policy don't even know about this. But here, it's a pretty essential part to my story, because this is actually fact. Almost 100 years ago, there were a group of leaders who came together and said the American healthcare system has so much promise to deliver good to the American people, but it's an absolute crisis. And especially, it's a crisis of cost. Healthcare, by God, was 4% of the gross domestic product. And hospital care, it was as much as $10 a day. Can you imagine? A situation that was intolerable to their thinking. Being a little lighthearted about how their approach to it, but it really was a group of people sitting like 50 years later when I started my career talking about the system, except this was 1928. And they came together with some foundation money to do a 5-year study of the American healthcare system and how it could be fixed. It's an important backdrop for my book and the historical fiction approach that I take. One of the current characters in my book, her descendant, was the chief clerk to that committee. And so using that, I talk about what happened with that and then also what happened through American history over time. And again, in an entertaining way where people are likely to follow the story rather than fall asleep to it. I can prove to you that it's real for 3 reasons, one of which is I actually have a copy of the official results. It was actually published in pamphlet form, including especially to the physician crowd back then, but they also compiled it into this red book on the University of Chicago Press. And it's really pretty thorough reading, really deep analysis into the system, and again, really eerily reminiscent of a lot of the things going on to this day. The other second reason why I can prove it was the research director for this was a guy by the name of Rufus Rorum. He's actually a character in my book in real life, and I actually met him. My mentor was a gentleman by the name of Bob Sigmund. His mentor was Rufus Rorum. That's how I learned about the Committee on the Cost of Medical Care. And it was 1985, I was in Chicago. I was on a fellowship with the American Hospital Association, the Blue Cross Blue Shield Association. And Bob was getting an award, and Rufus was introducing him to get the award at a dinner that night. And Bob invited me to come over and meet Rufus at his hotel room before this event. So I was in 20s at the time and kind of really nervous about meeting this famous guy. And what I remember was me being a little bit loose with my talk about what I was working on in my fellowship and I mentioned health insurance, and I got a 15-minute lecture about the difference between insurance and prepayment, and how the true concept we're after is prepayment. So for the rest of the time with him, I was really careful about what I said. But a really delightful guy, and Rufus is a prominent figure in my story. But the even better reason why I can prove it's real is these were the recommendations. They didn't have a PowerPoint back then, by the way. So let me just quickly give you a sense for them, because these are important, because some of the threads of these are important pieces of what tried to happen over time in American history, but mostly didn't. I call it unrequited health policy. So the 5 central recommendations, which were hotly contested at the time, one was medical service through organized groups. Back then, it was mostly independent physician practice. There was some group practice going on, actually notably, first in the Seattle area. But the idea was to somehow try to deliver care through organized groups rather than as solo practitioners. That's an important concept that's continued to flow through our policy history. The second was strengthen public health service, the notion that it was a governmental role to work on the public health, which wasn't really that well understood back in 1928, but we understand a lot more of the importance of it just over the last couple of years. The third and most contentious was to manage costs on a group basis, meaning insurance or health coverage through taxation. And this was the one that got the really fierce opposition, especially from the medical community, the American Medical Association. The third was to coordinate the state and local level. It's a recognition that healthcare is a personal matter and healthcare policy is really a local matter, and that somehow policy should really dig into that at the local level and try to make sense of it. And the fifth was professional medical education. Before this, in 1910, there was the Flexner Report, which really revolutionized the thinking about especially physician training and the need to really bring science and some structure to that process rather than just let people declare themselves as physicians, which was what was happening. This took another whole step by saying there needs to be more of that. We need to apply it to a whole range of health disciplines. So these were the core 5 recommendations. Said mostly these things did not happen. One of the things I bring to bear in my book is I try to give a typology that's easier to follow than the long history of health policy, which is typically you get in the major books about this. So I divide American healthcare into 3 distinct eras. Before we get to the eras, though, you have the early history of the American healthcare system, which does deserve a little bit of conversation, mostly because it was so grim. People went to hospitals primarily to die. Because their life was ending or because the hospitals essentially killed them. This, I don't know if you can see the picture well, this is, I believe it's Philadelphia General Hospital, and it shows an operating room suite and people in gowns and a bunch of students and others watching the procedures. This is actually a really nice picture of what this era looked like. This is probably about 1910. But certainly earlier than that, and even then, you're more likely to find people standing in sawdust without any gowns on, no antiseptic technique, the quarters actually being much more confined and sort of almost looking down, and no anesthesia and groups of patients being worked on at the same time. And so big shock that just about everybody died, sometimes from the procedure, but usually from the infections they got afterwards. That was American healthcare, and certainly hospital care. The hospitals were there mostly for people who didn't have resources. If you had any money, you stayed home and died at home, and were taken care of there, where the risk of infection was a whole lot lower to start with, even though they didn't really understand that's what was at play. In terms of the physician community, it was self-regulating, not in our current sense of self-regulating. It was, you regulated it yourself. You want to be a physician, you just called yourself a physician, and you were. And so all sorts of people were just out there hanging up their shingles saying, come see me, and we'll do whatever. There wasn't a heck of a lot of insurance coverage, because why would anybody really want it for the state of the art that it was? And again, mostly early history of American healthcare was not anything to write home about. There were actually an incredible amount of medical discoveries going on, not just in America, but across the globe, and especially in Europe, and going back to the 1850s, including around the germ theory of disease, the tremendous mind shift to recognize that disease doesn't come, originally it was thought there were these rotting things of matter, and that's how disease spread out into the air. And it was only later when we got to the germ theory where it was clear that it was germs, but it was human-to-human contact. And that's where antiseptic technique came in. So that was a huge discovery, as well as anesthesia. You know, we all know the Civil War stories and the pictures of these horrible operations, people with no anesthesia at all, and it's just holding people down and doing gruesome things to them. Well, that was American healthcare for quite some time. My point about raising this is these things were being discovered in the 1850s, but they were really slow to get adapted into the system. Everywhere, but especially America. So if there are those of you who are kind of wondering why we could get to the place where the notion of a COVID vaccine would be something that we don't really want to trust and do, it's actually in our DNA to reject these things until all proof to the contrary is before us. There really was a host of skepticism about all these treatments. Oddly enough, what changed it in this great history was a world war, 2 world wars. First, World War I. There were actually some great discoveries that were applied in World War I. One was they actually did typhoid vaccinations for troops because it was such a killer in previous wars, and they had huge success with that. But meanwhile, they didn't get the next step right, which was our last great pandemic, the Great Flu epidemic of 1918. That was actually, the World War was one of the precipitating events that took it global and to such scale. I don't know how much you know about that. I used to be the only person I knew that knew anything about this, and now in the last couple of years, a lot of people have read up on this. But probably the prevailing wisdom is that one of the reasons for the Great Flu epidemic of 1918 to be so lethal, and the estimates are, they're crazy estimates, like 50 to 100 million people across the globe perished from that. 650,000 in the United States. But part of the theory about that was that an inordinate amount of young people died from that flu, that there was a mutation in the virus, and the mutation triggered an accelerated response of the immune system. So it was young people in particular where that immune response would kick in, and so they'd get the flu, and then they'd literally drown internally from the response they had. And what do we know about young people in world wars? That's who's soldiers, boys going to war. And so taking people from all over the country, putting them on trains, sending them to close quarters in their barracks, and then going across the globe. And you can imagine how that thing just spread like wildfire, which is why we get the numbers that we did. So World War I, some important lessons about that. But it was really World War II where we started to see a shift in terms of adapting both the germ theory and the notion of using anesthesia in terms of battlefield casualties. And I just talk quite a bit about this in the book in one chapter. I won't belabor the point except to say that it's coming out of World War II, where for the first time, especially in the United States, where the rest of the world was devastated, and we instead come out on top and didn't really have any battles taking place on our soil, that American healthcare started to be looked at for the first time as a good thing, and as a good thing and as a public good. And that's what triggered really the modern stage of American health policy and the beginning of the evolution of the system as we sort of know it today. So let me just cover the ages of modern health policy, and I'll give you a flavor for it. There's a lot more in the book about these, and again, simply written to try to explain what these things are. I've actually given this speech to HFMA before, back when I was really working for a living, and I actually incorporated this, but I've really refined it in terms of an approach for the book and for this talk. Really I think there's 3 distinct eras of American health policy. There is some overlap in these, but I think they also kind of can be dealt with sort of as singular things. And I think you'll get the point pretty quickly. First of all, there's what I call the age of more. And this was the post-World War II period where healthcare was a public good, and we wanted more of it. It was a good thing to have it. So first start with anesthesia. Suddenly, all sorts of surgical interventions were possible. In order to do surgical interventions, the prevailing thought, which wasn't actually bad thinking at that time since they sort of started to get the understanding of the antiseptic technique down, was that we need to do those surgeries in hospitals. There weren't enough hospitals to do it. Congress passes a law which includes all sorts of financial help to build hospitals across America. And the number of hospitals, the number of beds just explodes. Similarly, physician capacity and other practitioners, there was money pumped into that to allow that to to satisfy this new demand for health care. Health coverage in the workplace. Again, health coverage really wasn't a thing. There were some back in the 30s and the 40s, especially around as Blue Cross and Blue Shield developed this phenomena across the country. But really it was after the war where things kicked in. It was actually in the war where we had the first major policy decision about healthcare, although it was completely unintentional, and it had to do with wage and price controls. There was still a lot of competition for employees, and a lot of the workforce was off fighting a war. So wage and price controls were implemented, but it didn't cover benefits. And so employers were allowed to compete, and they started competing around health insurance benefits in order to entice workers to come and stay. Actually, during the war is when the IRS came out and said that that's actually a deductible expense in terms of taxes, and it created this supercharged impetus to say, we don't have to pay our employees, we can attract them just with health benefits, and it's a really great financial deal because the tax bill is non-existent for it. And that became one of the major stimuluses for health coverage in the United States. By I think 1940, there was probably maybe 9% insurance coverage in the United States. By the 1960s, 50s, 60s, it was up to 50%. And then, of course, we had the big kicker, 1965, the passage of Medicare and Medicaid, but Medicare was really the big ticket. It was the notion of not covering everybody, but covering especially senior citizens over 65 through the payroll tax. Initially covered like 6 million people, now it's 119 million people, I think. So again, this is the age of more, simply put, just growing. And of course, the consequence of that was a huge increase in cost. Medicare passed with some estimates that were just completely made up and were lowballed, I mean, incredibly lowballed. But what we saw as an impetus of all the things at the age of more was an incredible growth in the cost of healthcare. I'll put up a slide in just a second showing the increase in GDP over time. What I'll say for now as I lean into that is to say the next stage of American healthcare became one of the age of rationalization. Not rationing. This was actually when I started my career, was when the age was getting underway, and the talking points then was we can't do these things, or if we don't, we're going to have to ration healthcare. And then somebody else would say, yeah, but we ration healthcare already through the emergency rooms. And that's not what this is really about. It's about how do you make the system rational so it works instead of just saying we're just going to keep throwing more at it. And there are a whole series of initiatives around that, some of which actually I think coincide not accidentally with the growth of HFMA nationally and the chapters. Starting with, of course, my favorite, this is before my time, but when Medicare was first passed, the question was how do we pay the hospitals? And the decision was, well, we'll pay them based on their estimate of costs. And on top of that, we'll give them some more. It was cost plus reimbursement. I met some of the old HFMA people back then when I was starting my career and asking them, and they would just laugh and say, we were so smart, we never lost money. and of course, that's what we saw happening in terms of healthcare costs was this tremendous growth. Well, cost plus reimbursement went away pretty quickly as a matter of rationalizing it. But then we started to get into things about what's allowable costs. I know that's really more about physician costs, but it's the concept of saying there's regulatory ways to say we're not going to allow that cost, we're not going to allow this cost. Tinkering. There was tinkering with something called the Professional Standards Review Organization in 1972. Raise your hand if you recognize any of these things from your career. You know, just older than you. This was actually one of the first projects I ever worked on. And it was the beginning of utilization review. Say, well, if we can't control the price, we're going to try to control the units and say these things are not allowed, and it became a big fight with physicians over whether their care was being reviewed by the government, and it wasn't okay. So that didn't take, PSROs didn't really take, but the concept of utilization review clearly is alive and well in its own aberration currently. Again, there were a whole series of initiatives. And some of these were kind of these bite-sized things, and some of these were bigger in concept. I'll just cover, in the interest of time, a couple of the really interesting ones. One of the most interesting for me was health planning and certificates of need. This was the pinnacle of the thinking of the age of rationalization. What could be more rational in saying, let's try to plan the healthcare system, and let's try to plan the healthcare system locally. It was the federal government providing grants to local entities and the state to do planning at their level and to really think about what do we want in our community? How many hospitals do we want? How many beds? What types of services? What equipment? And this was in the 1970s. Hundreds of people would get together every night in America and talk about these things and try to come up with plans. and it had some really great promise, but it never really was able to take. Partly because it just didn't get enough time to have the results show. Planning and the results have a timeline to it, and it got cut short for political reasons. But, said it had a lot of promise. One of the other things that really killed it, though, was the certificate of need part of it. The people who designed it said we should put some teeth in it, and it was the notion of capital controls. And the capital controls were a good idea in one sense, but they're a bad idea in that what it unleashed was dozens and hundreds of lawyers challenging the applications that were denied by planning agencies because they said you didn't need the service. A lot of them on constitutional grounds. I'm a lawyer, so I can understand these things. And I wasn't sure they were winnable cases, but they sure could slow things down. And it would slow everything down to a crawl, and there would be no results, and there would be political pressure, and ultimately, almost all the projects got approved. And so critics started pointing to that and said, see, health planning doesn't work. The real thing that killed it, though, was actually the election of Ronald Reagan. It was an odd byproduct in what he was running on in terms of changing how we think about American policy. And this is kind of one of the symbols. And they didn't actually really kill it as an intellectual matter. They just took the money away from planning. And it kind of just faded away like old soldiers. So that was the end of health planning. And really, I think that is actually a concept that had a lot of possibilities, as did the HMO movement. Again, the short version of that was there were also grants and loans to try to stimulate organized patterns of care, much like what was called for in the commission report. But what they did was open the door on alternative forms of HMOs, independent practice associations. And so while there were studies that showed you could save up to 40% from the fee-for-service world if you put people into these types of organizations, the organizations got funded had marginal savings because they didn't have any of the controls of those types of HMOs. Oddly enough, diagnostic-related groups sort of fits into this, and I say oddly because it's really sophisticated price setting, as you all know, and same with RVUs and its related concepts. Having gone through this, though, the odd thing to me at the time was it was really being billed. The rational part of it was this is the introduction of competition in the marketplace into healthcare. I didn't really get it then, and I don't get it today, but it was really the beginning of hauling out a whole bunch of proposals that said we're going to try to use the market to govern healthcare rather than the government. And that was the vehicle they pointed to, which seemed, and still seems crazy. It didn't work. None of those things worked. Some small ways. And the cost of healthcare just exploded. You start at the bottom. I'm sure you can't read that, but 1960s, you just see this incredible increase, especially through the age of rationalization. While things were getting rationalized, we were looking at the GDP percentage of healthcare go from single digits into 10. Early in my career, I remember this talks of, it can't possibly go above 10%, can it? And they were going like 12%, 14%. We're now projecting it's going to be something like 21% very soon. And it certainly slowed quite a bit in recent years, but the real explosion was back during this time when we were trying to make sense of it. The other thing that happened, though, was all these things were tried, and they just kept getting layered on top of the healthcare system. Some of them were government-based solutions. It didn't click. Uh-oh. We seem to be frozen. I'll have to do this without that. I had a picture. It's a labyrinth of what health policy looks like. And there were all these market-based solutions imposed upon the system over the course of about 20 years, also government approaches. And it just became this bewildering maze of how do you actually manage the healthcare system in America. And impenetrable. I was supposed to be an expert on it, and I'd look at pictures like that and go, I have no idea. And the point was nobody had any idea. And people still don't really have a clear idea because it's just as confused. And so the combination of attempts to try to solve it using incremental thinking only made the problem worse. You got it? Thank you. There it is. You might have seen that picture. This was the type of picture you saw during the third era of America healthcare policy, which I call the reform era, and we're actually still in that. And it just became essential to try to somehow crash through that and do it in a bigger way, We mostly think about this era around presidential administrations, although really there's only one president on here who actually had it happen on his watch. Jimmy Carter had some early efforts. There's a voluntary effort to try to constrain costs. He was going to do wage and price controls. The system said, oh, let us take care of this on a voluntary method. And they actually held down the cost of health care in that 1 year pretty well. And as soon as he was gone and that threat was gone, it just exploded back up again. This classic how things happen. Really, what's worth pointing out a little bit more about is the Clinton era, mostly because of its abject failure, but had important consequences. Of course, Hillary was put in charge of it and became this really clumsy, really poorly thought out process that crashed and burned. But also the consequence of it, it coincided with when Newt Gingrich was starting to rethink how he thought American politics should work in terms of the minority party. The combination of that and healthcare reform ended up with the House turning Republican. The lesson that many, many people got out of healthcare reform back then was don't ever try to do it. It's just political suicide. We had a version of that happen in Washington State. I'm actually part of the lobbying team, and I actually wrote part of the policy, which was at the same time there was a lot of state reform going on. Washington State passed its own healthcare reform, which some of you might remember. How old am I? God. But it was passed in 1992, and it was going to use features of the Clinton approach, but not the same way. It was really going to use competing health plans, and everybody was going to be covered. I worked for the State Hospital Association at the time. We agreed to a hospital tax to fund it to get everybody covered. And there were all sorts of other features, and it was really well thought out. It was a really good law. Well, the politics from that coinciding with the national politics, which all got jumbled together in voters' mind, was the state house in Washington went Republican too, which is not a small thing to say in this state politically. And so again, the lesson out of that was healthcare reform can't happen. It became described as the third rail of American politics. You touch healthcare and you're just going to get electrocuted. And it was just a terrible thing and everybody should run away. And in fact, most people did run away. A lot of the advocates for healthcare reform said, I'm no longer going to do this. The politicians, you couldn't get them to sit down at a healthcare meeting for fear of being seen. And it looked like the American healthcare reform dream was sort of just blown up. But it was never really that far gone. I'm proud to say that my organization, the Washington Health Foundation, me personally, we were saying the need for healthcare reform did not go away, nor did the interest of the American people in reform go away. We did a lot of work in terms of polling and meetings with the public, focus groups, were what we identified in this state, and there's a lot of this work going on nationally that we found other partners to work with, that showed there was a lot of frustration with political solutions to reform, what came out of the efforts to try to do it. But there was more than interest, there was actually almost an insistence on the part of the public that we do something about the healthcare system because it was so bad in their mind. It was like the number one issue, the number one problem for Americans was healthcare. And they were wondering why nobody was trying to tackle it in a bipartisan way. The other thing that was true, though, and states really started to recognize this more than the federal government, but it started to coincide and came together around the Obama years, was, again, it's another thing, you might think this is silly, but there was a time where governments thought they shouldn't spend more money than they had. Go figure. And the reality was, states in particular, because of the impact of Medicaid, but also the federal government, were having huge financial problems, almost entirely driven by healthcare costs and that precipitous growth. It was really pushing out their ability to do anything, in particular around education. And so there's this huge impetus to try to figure out how to tackle the state budget problem, and in order to do that, you actually have to square up to the healthcare issue. So my organization did a lot of work trying to change the paradigm in Washington that said, Washington State, that we can't touch this issue. We did work on across the nation as well, to some extent. And one of the great things we did, I'm still really proud of this, was we held meetings all over the state to try to see what people would say about it. And these were structured community meetings, every county in the state. And they were not the usual bitch sessions that advocacy groups would set up. We'd sort of force people to actually have real conversations about values. And what we were finding, if you put people together, they were really able to come together and get agreement. Not just consensus, but pretty strong agreement. The one thing that they all really agreed on, though, was it didn't seem like anybody in politics or government really cared about what they had to say. And they said, we appreciate you asking us, but will you tell the people that run the government that we should do these things? And so what we said was, well, we can't promise we can tell them. We can't promise they'll listen. But what we will do is we will hold a leadership summit and invite all these people to hear what you have to say. So we spent a whole bunch of money and had this leadership summit and brought the discussion and the values and the propositions to 350 people came together down at, I think it was then Safeco Field, or one of the fields. The process we used was, we had these 10 values that came out of the process that Washingtonians cared about. We used electronic voting to say, let's sort them out and figure out which ones are most important. I'll never forget, because I was talking like up here and the crowd was out there, they're all doing the electronic voting. And then the idea was we were gonna see when we had the top three, if we put them into a resolution that read sort of like the Declaration of Independence, who would sign on to it? The funniest thing for me was I was standing up here, all the Republicans, and we had a number of that's about everybody running for governor in there, they were all heading to the back door to hang out by it. Because one of the values was, we need more money. And they knew what that meant in terms of politics. Another value on there was reallocate existing resources. But they were expecting that we need more money to come out because that's typically what happened in processes before. Well, in fact, when we did electronic voting and nobody really knew what other people were doing, reallocate existing resources came out number 3, and more money came out number 10 on the list. And they all came back from the wings, came in the room, came up on the stage and signed the resolution along with the Democratic candidates for governor. There was also this moment where I was standing with them and I could see them looking out over the crowd going like, healthcare is not a killer issue in terms of politics, this actually can work. And it was the beginning of some revitalization in this state about trying to do something about it. The presidential election back then, right after that, the Obama election, it wasn't really an issue. Hillary wasn't going to go anywhere near it. The Bushes and Romney actually did some work out in Massachusetts, but it was not going to become a part of the Republican platform. And Senator Obama wasn't inclined to do it, but quietly there was work going on behind the scenes, including conversations with our organization about what we were finding, about interest in healthcare reform and whether he should try to do anything, and if so, what. So I knew there was interest in that, but I was a little surprised when he came out strong in the beginning of his first term and tried to do something, and did something. So it passed. There are 3 features to it: health coverage, public health fund, system redesign. In case you think I'm some left-wing nut, I'm pretty critical of this, what happened, because I thought there were features that were really good, the health coverage parts, the exchanges were clumsy. And I talk a lot about this in the book through my characters. But there's a lot of lost opportunity, especially around system redesign, where they really punted on a lot of the things that could have been done to make the system work a lot better and more like what the Committee on Affordable Care would say, Cost Commission would say. But they didn't do it. And so we're still living that story of what to do about it because it's an imperfect act. And recent years, what it's become is really just defending turf. Oddly enough, I found myself in Arizona doing that, first passing Medicaid expansion, and then this was the moment, right before the moment when John McCain did his famous that. And if I had more time, I'd tell you the story. I'd do a little bit in the book about what we did to try to get him to do that. Again, not as political fans of the process, but if the repeal of the Affordable Care Act went through, it actually would have killed Arizona as a state economically. It was the basic case we made to him and others. And there was really no policy replacement offered as a solution. When that moment happened, people have said that, well, that's the end of challenges to the Affordable Care Act. Given the current political craziness, I'm not willing to say that. But we are in this period where we're trying to figure out what it is we need to do next. And that's part of what my book tries to do, is offer some insights into that. We still have a lot of the same old problems, which my old talks I used to spend a lot of time on. And then we have this question, which I decided to punt on for now, is what does all this COVID stuff mean? And all the things that have happened, especially around trust with providers and hospitals and the total craziness of it. I don't have any answers for you, but I can tell you my next book is going to be about this. The title, working title, is The COVID Murders. So watch for that later this year, early next year. And I'm going to do sort of a similar version of this book around that. So the theory of Irv is my attempt to bring some entertainment and a way to understand all this together. The characters that I have, all of whom have personal things with healthcare that affect their lives. This is one of the things about healthcare as a system. It affects almost all of us personally. And not just because we need it, but because usually something goes wrong. And so there's a really personal understanding that people have about what we need to do to make it better that they try to understand and translate for themselves. And so that's an important part of my storytelling in the book. But they also have this opportunity, because of the way the medical detective story plays out, they have to deal with the defects of the American healthcare system, and they have an opportunity to try to fix it. So I came up with 10 basic recommendations. They're pretty simply stated in the book because I wanted them to be conversation starters, not enders. And I'll do a quick run through and then I'll stop there. And I think we'll have a little bit of time for conversation about any parts of this that you want to have. So let me run through these quickly. And if there's any of these you want me to explain a little bit more in detail what my thinking was, happy to do it. They do reflect a lot of the thinking I've had over time on 50 years of trying to unravel this problem and what to do about it. And I'm no longer cursed by having to work for an advocacy organization where members tell me what I need to think. I can just say what I want now. There's some freedom in this. So first, national health goals. We actually proposed this around the Affordable Care Act when it was going on as the Washington Health Foundation, that we should adopt a clear and articulable set of national health goals, no more than 10 with clear metrics on them, and we should hold ourselves accountable, including Congress, to the achievement of those goals. Why? Because this is the only way the American healthcare system changes. We know this. We know this from the quality work that I know you're mostly in the financial world, but that's some of the major improvements in quality in hospitals has become because of the adoption of clear standards and goals around harm reduction, numbers. The system responds to that. It is the only thing, in my experience, the system really does respond to, is when you really articulate measurable goals that people have to achieve, or there are consequences. So what we were saying then, and I'm still saying, is we need to adopt these national health goals and have these be the pathways to forcing the system to respond, or we're just making believe that we're really committed to change. An important part of that also, a subset of that is, and we need to understand within that health disparities, especially racial and ethnic disparities exist, they have existed. I'm not sure that, especially now in the conversation about why that is almost counterproductive. But using metrics, you can actually just do something about it, and they'll either get better or they won't. And that will be the way to sort of get your way through that issue rather than some of the current culture wars we have going on. Second, important to your world, I do say that part of the second one of those goals has to be about cost. Whether it's lowering the increase, whether it's lowering the base, whatever it is, there's got to be a clear, articulable national health goal that we are going to achieve, or there will be consequences. Third, and try to somehow achieve that, bring out sort of the concept of global budgeting as a methodology. But mine is regional health budgets. And I do that intentionally to try to break the state-federal nonsense politically. So instead of having the state-federal wars about things and how things play out, have it happen regionally, which over my lobbying experience, there's a lot of time where we said things happen differently, not in states, but in regions. So I don't really articulate what those regions are, but try to have a regional approach to budgeting, again with consequences around the goals and some other pieces that feed into that, and try to use that as a way to really get some impetus to do something about this and not just talk about it politically. Fourth, public option in the ACA. Might read a little bit more than I intended to in a simple form. All I'm saying in that is we should use Medicare as it exists. I'm now Medicare eligible. The base Medicare program is essentially actuarially something that anybody can buy into. So if you had one base program in the exchanges that people could buy into, and it's Medicare, that will actually immediately start to put some greater force in terms of cost constraint. I know health providers don't like that idea. I know if I still worked for a state hospital association, I'd be telling what a terrible idea it is because you'll get paid Medicare rates. I don't have to say that anymore. And what I can tell you as a Medicare beneficiary, I've never been happier with my coverage in the base Medicare program. Stronger anti-dumping statutes. Dumping is actually one of the underlying themes in my book, in the fiction part. And it really emphasizes the important role that emergency rooms play in the system, especially for rationalizing things for when things go horribly wrong. I'm saying they need to be stronger laws in terms of articulating them and enforcing them. And I say that having helped write the Washington law. And I think I've read that there's some things going on around that. I'll stay out of that, but I'll just say it's really important if you're going to use the emergency room as the backdrop to the system to allow it to have some strength in terms of doing that backdrop role.
Can you just give one example of dumping, though?
Chapter 22. No. Somebody comes in, has something that you can arguably say I've stabilized them, but instead I send them off to a clinic where they can go get care later. And in fact, they've had something much more severe, which is debatable, and they end up dying on the way to try to get that care.
So it's dumping patients?
Patient, oh, absolutely patients, yes.
So it's not like there's excess drugs and it gets dumped someplace.
Oh, no, I'm sorry. I'm talking about patients going in, hospitals obligated not to treat, but to stabilize, evaluate and stabilize them. I'm saying you really need to have some greater teeth in it, so you don't get to go in and say, well, they looked okay to me, and I send them across the street or down the road, which is what happens in my book, and the person didn't make it down the road. That's a dump. And that does happen in America more than we'd like to think. 6, this is an odd one, National Healthcare Lottery. So maybe we won't be able to cover everybody, but one of the great values we have in America, we certainly have in Washington, it was a top-rated value in our process we did as the Washington Health Foundation, was fairness, assuring fairness. And we seem to find fairness in lotteries, just generally. So my idea is that, well, if you can afford to pay for some thing that typically is not covered by insurance, go ahead and do it, that's fine, if you want to object, but everybody should have a chance to get it. And so somehow basically do a lottery where you can enter your name to say, I'm going to get that, whatever it is, kidney, new brain, I don't know. I'm trying to be a little jestful here, but the idea is real of if there was some way for people to think they had some shot to get it, that had some fairness to it, we'd be so much further along than where we are today, where those decisions are sort of being made through the back door in ways that clearly are not fair, other than by having money, which doesn't seem to be fair enough in the way that works. Sounds really crazy. I will tell you that Oregon actually did something like that, and I can tell you more about that if you're interested. More general public health funding. When I first came to this, it didn't seem like that big a thing. Maybe we all understand a little bit more about that we need some more funding to the public health system. Now, of course, and I think this will come out in the COVID murders, we're going to need some thought about how that system actually works because of the great challenges of the last couple of years. Many of those challenges were already in place before, but it really just started to crumble under the force of some of the difference in thinking about the virus. Professional education expansion, I put it up here to continue the thinking of the Flexner report and the commission report, but really my point is we just want more of these people. In fact, we want an oversupply and use the oversupply to help push prices down. In fact, if you have a big enough oversupply, that maybe that will prove to be a good cost reduction force. Number 9, Patient-Centered Design Institute and the National Institutes of Health. Patient-centered care, just about every healthcare system in America calls that out as their core thing, and maybe 1% of them actually really believe it. The innovation here is to say, let's really think about patient care from the patient point of view. Going back to the last presentation, that whole thing about empathy, that actually is the core thinking you would have if you have a value of patient-centered care. Think about how it works for your patients. And sad to say, but I love so many people I work with in healthcare, that thinking has not really gone deep in American healthcare. It has not gone deep in American products as well. There is a guy by the name of Donald Norman, who back in the 1950s did a study about how we needed to figure out how to make American product design work better for people. It was a crazy book, and people laughed at it, but his thing was, well, look, there's all these people coming together to build these elegant doorknobs. And if you then put the door there with the doorknob on it, you get like 10 people, one of them will be able to figure out how to open the door. And that's what I mean, it's that type of thinking. And there are ways to do this that his book describes in terms of making the product work better for people. I'm saying get serious about that. And last but not least, an annual National Health Challenge. Really a competition around healthy behaviors. Big thinking, not just exercise and nutrition, but bigger thinking about our obligations to each other as well. And structuring and do that. Sounds like another crazy idea. The Washington Health Foundation did 7 years of what was called the Governor's Health Bowl, where that's exactly what it was at the state level. And I'm suggesting we could do this at the national level. And as part of the prize of that, have some of the money flow back into the global budgets by regions to the winners. Some more stuff to get the book, but you got some pieces of paper. Again, hope you check it out. The policy pieces are in there. They're mostly really entertaining. And the medical detective story is a page turner. The end. I'll let our leaders tell me how much time we have for questions. We started a few minutes late. Comments, questions? Ride me out of town on a rail? No, because they're heavy. And I'm a first-time author. I'm trying to figure out how to do all this. I've got some other talks scheduled. What we're starting to build in is that everybody would get a copy of the book as part of me coming to do this talk. You're kind of my guinea pig to see how this might work. So let me know how you think about it and if it's a worthwhile thing. And then I think we'll get more serious about making sure the book comes along. And we'll do a real book club then. Okay, then I guess we're done. Thank you.